is the only rural health research center in Canada governed by community-based volunteers. Partnered with several academic centers and healthcare facilities, Gateway aims to advance rural health teaching and research across Huron, Perth, Grey, and Bruce counties. Our mission is to improve the health and quality of life of rural residents through research, education, and communication. A little over a year ago, Gateway launched this virtual lecture series. With social isolation being top of mind as COVID-19 restrictions continued to heighten, there was no better time to launch this initiative. Through this lecture series, our hope is to promote a culture of rural health, knowledge, and innovation, while virtually connecting individuals and communities to help reduce social isolation. Those of you who attend all lectures in this series will receive a diploma recognizing your commitment. Let's take a moment and meet today's presenters. Dr. Paul Gill is the chair of digital health with us here at Gateway. When he is not working with Gateway, Dr. Gill has many roles, which include an anesthesiologist and family physician in Goderich, a clinical lead for Ontario Health West, serving multiple roles, consulting on digital health infrastructure across our province, the Southwest Regional COVID-19 Response Clinical Lead, the Southwest Regional Cancer Care Ontario Primary Care Lead, Huron Perth Digital Clinical Lead, the Provincial Family Practice Anesthesia Executive. He's also a researcher and a faculty member teaching medical students and interns from both the University of Toronto and Western University. Dr. Gill's lecture today is titled Digital Health: How do we navigate care with a doc in a box? With Dr. Gill today are panelists Jessie Brown and Matthew Maynard. Jessie lives and works in Exeter, where she is a social worker with the South Huron Hospital Association. Prior to this role, Jessie worked as a social worker with the Huron Perth Children's Aid Society. Other than living in London while attending Western University, Jessie has always lived in rural or small town environments. Given her rural roots, rural health is very near to her heart. Matthew Maynard describes himself as a patient, a family member, and as a caregiver. Living with a lifelong disorder means being a regular user of the Ontario healthcare system. Working with the Huron Perth area Ontario Health Team since 2019, Matthew provides support and advocacy as the community connector at the local community food center. As well, he is co-leading the Be Well, Work Well project, which is assessing the mental health needs of employees and employers in Huron Perth. Thanks to all of you for taking part in today's session. Now, Dr. Gill, over to you to start today's discussion.
Can you see my slides?
Yes, I can.
Okay, so thanks for having us, and we'll jump right into it. So I have a set of slides prepared, and then we will sort of go to Matthew and Jessie in that order as we pivot to them, and then certainly open it up for questions. So as Paul shared, I have certainly been consulting in the digital space across the province for some time. The one role change that I will sort of share is I was past tense the Huron Perth Ontario Health Team Digital Co-Chair, but my role has ended as the next term with Dr. Craig O'Neill has taken over. So that's the one different one. And you may have seen during COVID in our region, the creation of a virtual urgent care that supports the west region of the province, including where we live here in Huron Perth. And so I was a strong proponent of that, as well as any remote care monitoring strategies for COVID. So those were things that I was heavily a part of. I'm also part of some advisory boards for Prescribe It and Canada Health Infoway. However, nothing that is in the talk today is influenced by any funding in any way. So I'll give a brief outline of what we're going to talk about. So I do want to talk about the pre-COVID-19 digital health landscape. So prior to COVID and 2019, 2020 sort of timelines, what did the digital healthcare world look like prior? And then what did COVID really do, and how did it accelerate digital healthcare in our province and in our region? I do want to also touch on the different kinds of digital health that exist. So, whether it's a virtual urgent care, like I've mentioned briefly, remote patient monitoring, online appointment booking, forms that your physicians or care teams can have you fill out virtually. Phone calls are technically considered virtual meetings because you're not sharing the same space. Video visits is what we typically think of, and Ontario Telemedicine Network was a strong proponent of creating that even prior to the pandemic. And something maybe that will be coming down the pipeline is email and text communication with a provider, but I think that's down the road. And then we'll talk a little bit about navigating and really spend a little bit more time on how to navigate those appointments. How can you be prepared? How can physicians be prepared? What are the right mix of things to do via phone or video instead of in the office? And what's not doable in the office? So let's go back to start way back to prior to 2019. And what I want to show here is really there's a study that was done by the Commonwealth Fund and CIHI in 2016, which showed that Canadians waited. Although 43% of Canadians were able to get a same day or next day appointment with their family doctor, 1 out of 5 had to wait a week. 1 out of 3 had to wait at least 4 hours in the emerge. And most Canadians, about half of them, had to wait at least a month to see a specialist. And 74%, despite that, actually were very happy with the quality of care that they got. So although Canadians were waiting, there was some demand for better access. And when we think about our Canadian landscape, how do we compare from a physician supply, which obviously will help with access, to other countries in the OECD nations? And so in 2021, you can see we were far to the left of that curve, which is less physicians per 1,000 than many of the other countries that we're compared against, but we were right in between the US and the UK. So supply was somewhat on the short end, so 2.8 physicians per 1,000 inhabitants. And if we look forward, again, this is from the same CIHI and OECD data, as you start forecasting to 2030, our volumes of physicians to actually take care of the patients that exist or our citizens that exist in our country are not actually increasing. Our numbers of physicians and nurses and healthcare providers graduating from schools, the enrollments are not increasing. In fact, we're seeing an older population of physicians with increased retirements. We're seeing physicians take on smaller roster sizes to attain a better work-life balance. So that ratio of the number of healthcare providers to the population may not keep up. And certainly that relative shortage, is called out in even as far back as 2016, which, isn't that long ago, but prior to the pandemic, we were struggling with this wave of retiring physicians, potentially making the doctor shortage worse. And obviously the pandemic is going to create a sense of burnout and potentially may exacerbate some of those risks. Looking to other jurisdictions, though, one strategy has always been thought of using virtual care to enhance access and actually provide a better ratio and a better, more timely way to improve access. And so, when you look at the NHS as an example, the National Health System in the UK, in 2018, they had a plan for every patient to have a digital first primary care option within 5 years. Now, obviously that may not have happened because of the pandemic, but part of the reason that they were pursuing this was they knew that there was data that it could improve timely access and overcome geographic barriers, which in a rural community we obviously face. And it was also thought to be able to add about 20% increased capacity so that those less remaining physicians could actually bolster and take care of more people using these mechanisms. And we were ready as citizens in Canada, myself as a patient, I'm sure other folks on this call are probably in the same place. 7 in 10 Canadians, based on an Ipsos Reid poll in 2018 in the Canadian Medical Association study, said that they would take advantage of virtual physician visits, and 4 in 10 said that they would do that for more than half of their visits. Canadians really did think that it would lead to more timely care, more convenience, which is a big driver, and better overall care. When you polled 18 to 34-year-olds, most of them were really strongly in favor, as were parents, in terms of navigating care. And I think the one thing that wasn't captured was caregivers, but there was a strong drive for caregivers who would typically have to come to a visit with their family member by taking a day off work. They could actually call in. So there was a strong drive to actually support virtual mechanisms already in the system prior to the pandemic as well. And what kind of healthcare did we want? Well, as Canadians, we kind of wanted everything, right? So we wanted all kinds of digital access. We wanted data liberty. And data liberty really refers to being able to access our own information, right? So if you had lab work done, you want to be able to see it, whether it's on your phone or logging into a portal, your own chest x-rays, the results of your consultations. And I think that concept of being able to access your own data freely and transparently is something that the healthcare system is obviously working towards, unfortunately slower than most of us would like, but it is working towards that. Canadians also wanted to be able to actually, have communications with their physicians, to book their appointments online, and to have virtual visits, whether by phone or video visit. So how are we doing as a country here in Canada prior to the pandemic? Well, if you compared us to the UK, in 2017, Kaiser Permanente based hospitals ended up having about half of all of their visits not in person. So whether they were phone calls, video calls, or other touch points such as asynchronous messaging, half of the care that was delivered through Kaiser Permanente's system in the States was already what we would consider virtual or digital first approaches. Whereas around the same time point, only 0.15% of billable services in Canada, based on CIHI data, was virtually delivered. And part of that was really the limitations in how our healthcare system sort of paid for those kinds of services, because those kinds of codes for providers to be compensated for care did not exist at all in our system. But the pandemic really changed that. So it accelerated growth in both the public and private spaces. And it was really a needs-based acceleration. Many offices, obviously, suddenly with the pandemic, were forced to rethink, should we be bringing people into our office when we don't have appropriate PPE or protective equipment, sanitary processes? Most of us were still trying to figure out what our infection prevention and control routines were going to be to make sure the office was a safe place for patients. And so this was one of the strong drivers, along with the government coming out with temporary compensation models for healthcare providers to actually provide care in a digital way or in a virtual way. And I think, the thing that we forget sometimes, and I mentioned this earlier, is phone visits really made up a huge bulk of the care. And the Women's Health Initiative study, or sorry, not the Women's Health Initiative, but the Women's College Hospital in Toronto actually did an interesting study looking at virtual care and preferences of patients. Would you want a video visit or a phone visit? And interestingly, I was very surprised that video visits were not as strongly favored as phone visits. So phone visits really took off in Ontario and actually across Canada. And certainly that has been the experience, even now that we are a little bit more comfortable with this idea of non-in-person healthcare. All the while, with the sudden change, I don't think, it would be surprising that in our rural communities, you may have realized that getting set up and getting all this infrastructure into primary care systems in the public system has been challenging for the healthcare providers. While balancing a pandemic, my offices and my colleagues were called on to set up whether it's online appointment booking, which my office is just in the middle of trying to set up in my own practice, whether it's figuring out how to balance going from providing care to a patient to walking into a room and trying to figure out the IT support. So how do I get my EMR to capture that patient information and go on to Zoom with a patient or onto an OTN platform with a patient or phone a patient? And how do we know in our calendar which patient is phone-based versus in person, and all of those kinds of things was challenging. And I think many physicians are feeling quite burned out, not just physicians, but allied healthcare providers are feeling burned out with the added task of setting up the infrastructure behind the scenes with really no significant support to do those tasks. And I know behind the scenes, initially when some of this work was being put together and we were switching to phone-based models, there was a lot of concern around the province about delays to diagnosis. So, if a patient wanted a phone appointment and they got a phone appointment, but it was for, let's say, abdominal pain or weight loss, could you actually be diagnosing a cancer later than you would have had that person come in for their first visit in person to begin with, because you missed the chance and actually pushed back that physical exam part of the assessment. Here in Huron, Perth, I think one of the other things that my office certainly has been trying to figure out is how do you balance providing online access or virtual access or phone-based appointments with those folks who really can't access care using internet-based modalities, and they really need to come in. So how do you keep it equitable, especially when rural internet bandwidth is not equal across our region? Who's going to pay the costs for all these systems? And in my primary care office, when you're talking about patient portals, online booking, reminders, systems to replace the fax machine and switch us over to systems that when I prescribe a prescription go directly to the pharmacy rather than a fax-based send of a prescription. All of these platforms from a cost and an integration perspective are actually different vendors, different companies that the primary care providers and healthcare providers are actually negotiating with and bringing into their systems. And with that, there's a lot of concern and slowness because we're trying to figure out, are these different vendors and companies safe? Are they going to have data leaks? Are they going to keep your privacy safe and guarded? What are the privacy implications? Do they integrate and actually pull information right from our electronic medical records? Or am I going to spend half my time in this patient portal just putting in your OHIP card again and doing more and more administrative tasks? And so there's been a lot of barriers to some of these technologies, mainly because they're so fragmented and they're so disparate and they don't mesh well together and they're not integrated. And it really has slowed the public system down considerably. And thankfully, there's work being done to help primary care and allied healthcare providers, whether it's hospital-based or otherwise, actually start to consolidate some of these many different platforms so that we're actually on the same platform across the board. But that work, again, is slow and it requires collaboration and agreement, which doesn't always occur. The good news is, as we switch into this virtual world and we start doing more and more care via virtual means, which again could be by phone, that most diagnoses can be made by listening. And so this is obviously a picture of from the movie Jerry Maguire, where he sort of Tom Cruise makes that statement, "Help me, help you." And so we're going to pivot a little bit to this idea of what, as a healthcare provider conducting a visit with a patient, what are the things that I'm listening for? And what are the things that we train our residents and medical trainees to listen for to help them make a diagnosis? And what we know from data, even as far back as 1975 in the British Medical Journal, 83% of diagnoses could be made by listening to the story that patients were telling us. And now, because these virtual visits often are not conducted in person, in fact, that's the idea of a virtual visit, we really, as physicians, have to go back a step and almost retrain with the thinking of really listening to what people are saying and really listening to those cues. And so we are spending a little bit of time in the educational world ensuring that our trainees remember those different cues and remember to ask the different things and frame the conversation in a way that helps them come up with a different diagnosis that could be at the core of what that visit's about and help them drive to that diagnosis sooner. Now, of course, digital doesn't end at asking questions and talking to one another. So certainly, you know, many diagnoses can be made just by talking, but 17% based on that last slide alone are not made based on history alone. And so more information is needed. And certainly a physical exam can help improve the probability of landing on the correct diagnosis. A physical exam is also a low cost. If you come into the office, there's not an added cost of setting up a test or a CT scan or an MRI. And certainly the value of adding a physical exam in many cases is very strongly present, especially in cases like abdo pain, where actually pushing on the belly may help you determine whether or not the gallbladder is an issue or if it's literally constipation or something else like that. Certainly, there are types of care that cannot be done without being in person, like pap smears or looking in an ear to see if there's an ear infection or an otitis media. But the physical exam is also starting to be virtualized to some degree. So there's some elements going into an appointment with your provider that you may be able to attain that we traditionally have pulled from the office. So many people have blood pressure cuffs now, they have temperature probes. A lot of people through the pandemic have gotten oxygen monitors that can tell us your heart rate and your oxygen level, and things like height and weight. And so those are many of the elements that we look for during an in-person exam. They're obviously not everything, it's a small portion, but even the different types of physical exam features that we look for are expanding. There are beginning to be digital stethoscopes that you can have. There are some companies playing with this idea of almost like a photo booth where you go in and there's all these different instruments that can be actually driven by the patient and collect information back to the provider and share it with them. Obviously, if the history and physical exam don't do it alone, investigations are sometimes needed. So blood work, imaging, ECG, all of these things. And the nice thing about many of these investigations, although they do add a cost to the system and they do require you to go somewhere to get those tests, most of them can be coordinated virtually. So, you know, the investigation portion has not really limited virtual care. It is sometimes being overused in the virtual world though. So where I have a patient who absolutely is not wanting to come into the office because of fear of whether it's COVID or something else, I am probably over investigating them because I don't feel like I have a different mechanism to get to the root of the problem. So that's something in the healthcare industry that we're going to have to sort of optimize and move back towards the physical exam because I think there is more yield in that space. So what are the things that I'm listening for? So when I'm training residents and medical students, whether as part of my role with the University of Toronto or with Western, I love this mnemonic old carts. And I've been trying to sort of teach my patients before they come in for a meeting to try to think through these sort of questions. And these are the questions that really help us drive and listen and cue for diagnoses in terms of getting down based on questions alone. So this is really, I think, the slide that if you're going to pay attention to one slide, this is the one that I'd want really shared. So a lot of times when I go into my own healthcare meetings, you know, I haven't really thought about my issue. I go in with, you know, I've got back pain issues. So I sometimes go in and my physician asks me questions and I kind of really don't know what to tell them other than it hurts and I don't like it and I want it to stop. Many of you are probably far more prepared than I am for your meetings. But when I'm listening as a provider, what I'm really listening to as a physician is onset. When did that pain start? Was it a month ago? Was it 2 days ago? That gives me an idea of is it acute or chronic? And there are conditions that bifurcate that really follow an acute pattern. And there's different conditions that follow a slower, more indolent or chronic pattern. And they may have different investigations that we follow. Location, so that's the L in old carts. Where does it hurt? Does it radiate? Does it shoot somewhere? Duration, when it happens, how long does the pain last, or whether it's pain or otherwise, discomfort, indigestion, whatever it is, does it come and go, or is it there all the time? Character stands for what the issue feels like. So is it sharp? Is it dull? Is it shooting? Is it tingling? Alleviating is really, what have you tried that or noticed that makes it better, right? In many cases, people have tried a whole host of different things, whether it's anti-inflammatories, whether it's walking, whether it's doing some physio. These give us clues as to what the etiology or the source of the medical issue may be. And sorry, the R should be what makes it worse, not alleviating and relieving. So I will fix that slide. But certainly, are there things that make it worse? So in the case of like a gallbladder, you may find that when I'm eating or drinking, about 20 minutes after you eat a really fatty meal, you get this pain in your upper quadrant or in your sternum sort of region related to that meal. So that may be a clue. Timing. So is it morning? Is it night? Is it after you eat? Is it when you bend? What sort of kicks that symptom off? And then severity, right? We really want to understand how severe that symptom is and how it affects function. And the other thing that we tend to teach residents is this idea, and this is kind of a bonus round, is really about fifing. So we often in our exams for family medicine want to make sure that we're not just asking questions, and really with an experienced provider, you may not even recognize they're asking you these sorts of questions. The old CARTS or the OPQRST is the other mnemonic that is used, or that the physician is fifing you, but they are so used to asking these questions, even without that structure, that they are actually bringing that information together to consolidate their thoughts and organize what the diagnosis may be. And in fifing, what we're really trying to do is understand how it affects you. So what are your feelings about what's going on? What are your ideas? What are you worried about? I've got some people who have seen me who have a third distant cousin who had an experience with cancer. And for whatever reason, that is really what they're most worried about, even though the presenting issue that they're presenting with very clearly as a diagnosis has nothing to do with that. And so understanding what the patient's ideas are or what the person's ideas are may help at a root level us to actually come up with a plan that is going to not only satisfy the individual who's meeting their healthcare provider, but actually address the root reason that they're there and address and come up with a plan that actually sort of resolves or finds the underlying issue. We'll go to the next slide here. So when is a virtual visit not really useful? So this is a slide from the Ontario College of Family Physicians that was put out during the pandemic while virtual care, kind of like the wild, wild west, was going on unabated. And so they really put out a statement saying that in-person care is still the preferred route of providing care, but when it's not really going to impact a diagnosis or care dynamics, that virtual approaches should be used. However, they really did say medical issues like undifferentiated acute problems. So not something that's been going on for 8 months, but something that just started and you have no idea what it is, and the physician's never diagnosed you with a problem related to this condition before. That probably should be seen in the office because a physical exam will likely be needed. Mental health conditions are often ones that are better in person. So certainly with patients that I have strong relationships with, I've been able to navigate some of that using virtual modalities. But when someone has a mental health condition and the virtual technology breaks down, it can be quite limiting and jarring. Certainly procedures, it's really hard these days with the technology that we have to do any procedure virtually. So, pap smears, joint injections, IUDs, that kind of thing, you really need to be in person. Anything that requires a physical exam. So if someone's saying, oh, I've got, a rotator cuff issue and I need to figure out which muscle it is, I probably need to bring that person in. Prenatal visits and child visits do require in-person visits still, and immunizations are tied to part of the reason for that. Those well baby or young immunizations that are due at the various stages of growth. Cancer screening. So, a lot of cancer screening can be done virtually, but when we need to go through very specific, like, as a patient who has breast cancer may need a recheck if they've had their cancer taken care of and now I'm surveilling their cancer, I'm probably going to want to physically examine that individual. For patients who can't speak in a public setting or at home because their issue is private and confidential or requires safety, things like intimate partner violence, we really do want to encourage in a safe way to nudge those to be in-person assessments where we can be sure that we have that individual in a safe space to share their health issue. And certainly, in spaces where virtual care is too challenging. So not possible for individuals with hearing loss, technology challenges, language challenges, cognitive barriers, because obviously, it may be one of those things where we call at the right time, but no one picks up, or vice versa. You're waiting on the line, you're there on time for your appointment, and we're delayed. And now what happens with the technology? Does it line up or not, right? And certainly palliative care has been promoted as being something that really should be done in person. But in my own experience, some of these, you can have a blended model where some of the care is done in person. And once you've got a plan, then follow-up care in many of these areas can actually be done virtually or by phone. So in my practice, many first-time new issues are in person, and most follow up for something that we've already come up with a plan with and seen each other about is done virtually. So how do patients feel about in-person? This is a study, an Abacus Reid poll that was done by the CMA in May of 2020 of 1,800 Canadians. And interestingly, whether you have complex conditions or very basic needs, the Canadians that were polled really still desired in-person visits in many of the cases. And the second best option for most patients, which again mirrors the Women's College study from Toronto, the second favorite option was phone. And video conferencing was really third. So I don't think face-to-face is going anywhere. And earlier, I had sort of spoken a little bit about our primary care offices navigating all of these new technologies, whether it's online appointment booking, whether it's video visits, whether it's phone visits, and how to make it all work and make it seamless and make it a smooth experience. And it has been anything but that, I think, for providers and patients because of all the different technologies and the lack of support in getting these things up and running. And in that space, there's been opportunity for private organizations and private companies to actually pop up with their virtual solutions as well. So many Canadians have been accessing whether it's your private healthcare company. I won't name companies. I've got a slide that shows a bunch of different companies, but really potentially some challenges where people are accessing care which is accessible, it's fast, but it may not be connected in any way with your primary care provider. And certainly your medical history is unlikely to be part of that assessment. So that may have some risks. And if you look at that paper in the Globe and Mail by my colleague in Toronto, Tara Karan, what she talks about is things like for-profit companies maximizing revenue, but not necessarily health outcomes. Some of the companies actually sell health data. Some companies have already set up their physician electronic medical records to advertise specific drugs to providers for a fee while they're navigating your care, and are contemplating advertising to patients specific drugs and therapeutics. And so when you think about the wild, wild west of this private part of healthcare, there are some risks of appropriateness, safety, information sharing. Do the providers on those systems know your allergies? Do they know your history of 3 years ago, what happened? And so those risks have to be balanced with access. So, is it safer to get quick access with some of these private companies for something simple, or is it better to wait for your provider? And there's not a right answer in this space. So I do think, over the coming years, we will see some of these companies that have really looked at the opportunity in this space and taken off with their businesses in these spaces. We will start to see, how do we improve safety? And that's probably, in my view, through some regulation that requires data movement from these sources back to your primary care doc, so at least somebody in the healthcare team knows, and data liberty, so that you as a patient actually have your information, whether it's coming from one of these or your primary care doc, so that it's consolidated in one place to allow decision making. So, in 10 years, I don't want to paint it all as gloom and doom. I'm certainly not against these private companies. I think we just have to be careful about how we bring them in. And they're going to be fast and nimble because they make a decision for their entire company. Whereas in our public system, each group is making their decision independently, and there's not a strong regulatory framework to push us all onto one system currently. But in 10 years, telemedicine and medicine is just going to be medicine, right? Like, I don't think in 10 years, we're going to say virtual visits are different than accessing a provider in person. It's just going to be a part of care. So when you call your doctor, like in many places in the States, in accountable care organizations, the mix is about 60% of care in person, and about 40% is done virtually. And I think driving to that target certainly makes sense. So I'm going to pause there. Those are the slides, and I'll just bring the slides down. I see some questions already popping up. And what we're going to shift to is I want to spend a little bit of time just having Matthew Maynard speak to his experiences from a patient perspective, navigating what technology means, especially when you have different providers providing care as one person in our public infrastructure, where there's so many different vendors being involved, different systems and software solutions, what that experience has been like. And then after that, we'll switch over and listen to Jessie Brown, who has a similar sort of patient story to share with us as well, navigating some of the challenges in the current world with digital. Matthew?
Yeah, thank you. Great to be here. And I think part of my reason for being interested was that during the pandemic and prior to the pandemic, I have a chronic condition that means I have to have constant contact with the healthcare system since birth. So I've seen lots of changes and lots of ways that it's changed, but in particular during this time of COVID, it has definitely changed. So I've been called on to, as a caregiver, to be on a medical appointment that was done by phone, which was virtually impossible. Do I tell them that you're on the phone with me, Matthew, or do I not tell them? And equally trying to cozy up in front of a web camera is a little bit challenging as well. But that became, it wasn't really part of a choice. It was part of how at that time in COVID that provider was willing to operate. So I think part of it is, where does the patient choice go? And how do we make that choice? How do we do that in an informed way that says, I'm gonna get the best help that I can get? And I think, again, as another example, I had in the last 2 weeks, a team with I have a standing appointment once a year with the specialist team. The physician had COVID. So the day before, I got a call that said, well, would you like virtual with the nurse and the social worker? And I thought, hold on a minute. How can I do a virtual with the social worker and the nurse and actually have a fair conversation about my needs and about, and for them to identify my needs. And so I actually turned it down and I said, no, like I might as well, if I'm gonna meet with a team, I had tried it once previous in 2020. I went, no, that is not going to work for me. So I am in that group that you mentioned, Paul, that has a chronic condition, and which would I choose? On the other hand, I had a minor surgery postponed at 8 o'clock in the morning after having driven an hour to get there. While I'm going through the COVID protocols, this particular facility had 3 stations, and I'm getting these phone calls. Well, it turned out the clinic was bumping me because a surgery had to be performed and it was going to interfere with my hours. But right at the time after the hour, I did end up getting that surgery done this past month. All of the follow-up has been by telephone. And as far as I'm concerned, virtual, that is an excellent use of a specialist time and excellent use of my time as a patient. Certainly if I had had complications, I would have known where to call and how to do that. But to have the follow-up was by telephone was absolutely appropriate. And I think the only other thing in talking about, it was old carts, right? It wasn't old farts, right?
Old carts,
Sorry,
yeah.
I couldn't help it. I wrote it down as old fart. But I think the one thing that I want to comment about, in that I do go with people to their appointments, and I find it harder in a virtual appointment to make sure there's an understanding of what the patient or the caregiver and the provider are going to do next. And I find that that's much easier in a face-to-face appointment than it is either by phone or by video. And so that's my one comment that again, I think I've said this to you before, Paul. I live with my disorder 24 hours a day, 7 days a week, all the years. I'm not going to tell you how old I am. And I get to see a provider maybe an hour a month at most. And so it leaves me with the expertise, but without the data. And so it's being able to plan what are those next steps to make sure there's an agreement about what next steps are. And you can call it discharge notes, you can call it what you want. They just don't seem to be part of a virtual appointment.
Yeah, so certainly, you know, you're speaking to the learning pains, and I think that learning pain of how do we actually have an encounter where a patient and a provider are getting together and have a meaningful outcome that can be digested and understood even after the fact. You know, although that requires quality improvement, even in the in-person world sometimes, I think that there's a lot more room for improvement of how that's navigated in a virtual world, whether it's, you know, an email with here was the summary of what's been done or talked about via our call today and sent to you. You know, those systems I think will come, but unfortunately, I think they're coming way too slow compared to all the other industries and sectors that, you know, banking and everything else that we are able to do. It just feels incredibly slow and pressured. So thank you, Matthew, for all the work that you do in Huron Perth, advocating from a patient experience side. I know I've pulled you into provincial meetings and other meetings because I think your viewpoint is so valuable to share and influence decision makers. And certainly thank you for speaking to that today as well. I think one of the things that you didn't speak about, just before I turn it over to Jessie, that you've shared with me previously as well, is is, you've suddenly needed to become an expert on every different virtual care technology as a patient, and how jarring that can be, whether it's, logging into one hospital system to get your data, and then a totally different system with a different hospital, or Life Labs or Dynacare. They all have their different logins, and you all of a sudden for your healthcare need 10 logins and 10 different clicks that you need to do with 10 different systems to take care of one person. And certainly, I've heard that loud and clear from you a few times, and we're trying to influence up the chain to say, that really doesn't sound like a great patient experience. And in fact, it may actually create patient risk. And if we're really serious about healthcare and digital infrastructure for healthcare, we really have to think about how do we decrease the risk that some of these new technologies pose because of their lack of integration. So certainly it's something that I think we should take forward. So Jessie, from a social work perspective, I know you work in Exeter at the hospital there. Can you tell us a little bit about your experience maybe with that patient example that you had, and then we'll take some questions as well.
Sure. The patient example that I have is with an outpatient who has been accessing our mental health services in Huron County since he was a child. So this is someone who's familiar with services. Unfortunately, needs have not been met. And it's progressed to substance use disorder, of course, coupled with many other mental health disorders. At the beginning of the pandemic, he was referred to a psychiatrist who specialized in this area. Of course, he thought, what's this going to do? What difference is it going to make? I supported him and tried to provide reassurance that, this is something that could really benefit him. It's something that he had not done. Unfortunately, the experience was not positive. And he did write some points down for me that he said that I could share. So the first point is the process wasn't really explained to him. I think as professionals who work with technology, we innocently make the assumption that everyone should know how to work this technology and what they will need for this appointment. And he certainly did not know. So he started the process. Thankfully, a family member, he shared with the family member that he was going to be doing this appointment. And they said, do you need help? And he said, yes. Otherwise, he wouldn't have opened his email. He would have thought, I'm a loser, I can't do this. So thankfully, he just happened to have a family member say, I'll help you. They got on. And unfortunately, it took about 20, 25 minutes for the person on the other end to get on. And again, for someone who is relatively healthy, 25 minutes can cause some anxiety, let alone someone who's not well and who doesn't want to be here and is quite embarrassed about having to share his story again to a stranger again. So 25 minutes happened. The person came on. Unfortunately, it wasn't the psychiatrist. It was a student that was going to be doing the initial assessment. I feel like that would have been okay if that had been communicated to the patient prior, because again, it was kind of like a letdown. Okay, I was told I was going to speak to so-and-so, and now I'm not speaking to so-and-so. So that was kind of hit number 2. And then the glitches started happening, the lags with both video and sound, which was really detrimental because having to repeat himself and repeat the things and behaviors and things that he has done over the years to people and was very hurtful and shameful. So when you're having to repeat it over and over, hit number 3. So eventually they switched to a phone call where again, he had to repeat everything that he had said on the video call. And then at the end of the call, there was no wrap up. There was no conclusion. So it's kind of like an essay. You do the intro. What are the goals? What are your expectations? What are your understanding? There was none of that happened. And then all these questions and having to repeat the answers. And then at the end, it was just kind of left at, okay, thank you very much. Your doctor will get a report. And then there was no follow-up. So when I get the call from the client, he tells me, well, that just made me want to use more because I felt not heard. I didn't feel respected. I had to repeat things that I do not want to repeat to anyone. So it really did him a lot of harm, unfortunately. So to take away from that, there's lots of improvements, of course, to be made. Again, we were kind of early on in the pandemic when this was happening. So those were some negatives, but I have had positive experiences as well with our inpatient unit. So there's negatives and positives, and hopefully we just learn from them all.
Thanks, Jessie. So I think, one of the things that you're describing, and I think Matthew alluded to it, that not closing the loop at the end of appointments, right? So I think one of the challenges with virtual care is that because even though you're close to people and you're connecting with them, you're not close to them. You're not, it's not the same as an in-person sort of contract or relationship when you're sitting eye to eye with somebody. And the ability to just hang up or hit leave on a meeting and move on to the next person as a provider, or the same from a patient, and then go, oh man, I don't know what the next step is. There's no recourse. Versus in the physical world, you get partway down. There's so many times that my patients have put their hand on the door and gone, wait a minute, what's the next step? Or, they walk down the hall and they go, oh, I forgot the form in the back, right? These kinds of things happen. And in the virtual world, getting all that reconciled or reorganized is actually pretty darn difficult without having mechanisms in place to deal with that reconciliation process. So, I think what you're speaking to is certainly, you're speaking a little bit to rural bandwidth and internet connectivity challenges, the need for help in navigating digital, but also, just how do we, in a seamless way, think about what is the parallel process in the physical world that's not being met in the virtual world. And we haven't really mapped those out yet. We've just jumped into this. And in my view, we need some floaties in that digital pool to help us sort of steer a little bit better as we do. So I'm gonna, again, thank you, Jessie, for sharing. I see Paul is joining us.
Thank you.
Again. And there's a couple of questions that have popped up. So one regarding, do you feel, this is from Dan Stringer, do you feel that digital healthcare will be the new future for medical assistance? I don't think it will be replacing in-person care by any means in the long term. But certainly I think, the more and more digital innovation takes place, it will be more and more a fabric of part of your healthcare experience. And certainly I think, if there's a hybrid world that we get to live in where, lots of follow-up care may be digital, where, if things are good and you go to London as an example, and you're on that pathway to maybe needing dialysis soon, and you get your first visit done, but you're not near dialysis, you can do your lab work at home and do your follow-ups with the London team without traveling all that way until you actually need to, right? So how much can we hybridize and actually use digital? But it's got to be in a way that actually provides superior care for patients, not just convenient. And I think there's a way that we can do that using digital and enabling that. So, but I do see digital care being much more prominent, right? So, and I'll give you another example with remote care monitoring. In COVID, we as the Southwest team, when anybody got diagnosed with COVID and was high risk and contacted us, we literally shipped them an oxygen monitor free of charge, connected them with nursing programs that were available to chat with them, set them up with Meals on Wheels, and really wrapped care around them so that when they were isolating at home, if they had no family nearby, one, if they needed an escalation of care, we could actually advocate them, call the hospital, say, hey, this person's coming with COVID, their oxygen's sinking, they need help, and have them come through a back door instead of going to a waiting room, right? So again, the premise there was, how do we actually enhance care delivery around the patient, not just add tools for the sake of adding tools? And so I think we're going to see more of that. I think it's going to be stumbling, or you're going to see, technologies come in, companies come into the marketplace, and then some of them are going to fail, and their failures are going to cause significant readjustment for the systems that utilize them, right? So in my office, we're just going into an online appointment booking world. If that company folds, it's going to be hard for my office to suddenly go, okay, well, I don't have that technology anymore. Now what do we do? How do I adjust and shift all my patients? How do I reconsent all my patients to this new system? So, you know, I think we're gonna struggle until we're a little bit more in that maintenance phase. And then I see a question from Bob Murray, and I'm going to kind of speak to it. Does the patient have a choice in the process? Of course, patients have a choice. And so the question from Bob Murray really has to do with triaging patients. And I think the question from the anonymous attendee afterwards is along the same lines. So, you know, in my office, certainly, you know, what we try to do is book people as in person as we can, because again, that is the preferred modality for myself. I think it's an easier visit, it's a straightforward visit, but we offer virtual as an option, unless it's a type of health issue that really I don't think I can do virtually, right? So abdo pain, really hard to do virtually because the symptoms are so vague and I actually need to press on the belly almost every time. Rash, really hard to do virtually because I can't feel the rash. Sometimes feeling it actually is the difference in making a diagnosis. And cameras, some cameras are great and I can see the rash really well. Some are awful and people are just getting close to the screen and showing me their face. And I'm like, I can't see what you're trying to show me, or they're showing me inside their mouth. And it's just really awkward and takes a lot more time to actually help someone than not. But behind the scenes, you know, the government in Ontario has taken part or done a RF, I can't remember what the letters are now, RFQ or RFP, which I was part of, which is part of a system called a healthcare navigation service. So we are launching provincially shortly an online healthcare navigation service which will kind of take the place of telehealth that has existed. And it will help navigate you to the care provider and help triage your concerns to the right place and connect you with care close to home where possible. So obviously that system is going to take some time to build, but in that there will be some triaging to actually say, hey, this is actually fine for virtual care and we're going to connect you to this virtual care team, or no, you should really talk to your primary care provider about this and we're going to connect you to their online booking system for their platform, right? So I think we're building towards these things and these systems, but again, it's going to take some time. Paul, do you see anything else there?
No, I think we're good. I think we're good. You've touched on the questions as they've come in. There are some comments, and I thank everybody for the comments and the questions that we have received. I want to take this opportunity to thank Paul and Jessie and Matthew for this conversation, sharing your knowledge, the information that you have, the experiences that you've had, both as in all the practitioners, but also from the giving us the sense from the patient side as well has really been awesome. I want to take this opportunity too to thank our sponsors for their continued support, because without them, this lecture series would not be possible. Our sponsors include CIBC Private Wealth Management, DeJager Town Square IDA Pharmacy in Goderich, CERH Goderich, and the Town of Goderich. Gateway is a not-for-profit organization with charitable status, and we greatly appreciate and welcome any support that we receive. If you would like to donate to Gateway in support of this lecture series and other activities that Gateway undertakes, I encourage you to visit our Gateway website and simply click on the donate button. Thank you again to all the attendees for joining us today. We look forward to seeing you at next month's lecture series, which will be Tuesday, May the 3rd, when our topic will be Great Local Food, Exploring Huron County's Food Landscape. We hope you enjoy it. We hope you will join us for this lecture. And also, please pass on this lecture series information to your own networks. We hope to expand the reach of this lecture series with the aim of promoting the knowledge economy, reducing social isolation, and supporting Gateway's mission of improving the health and quality of life for the rural residents. Thank you. And I want to wish everybody enjoy the rest of your day. Goodbye, all. Thanks.
Thank you.
For having us. Thanks, Jessie. Thanks, Matthew.